In the fetal circulation, pulmonary vascular resistance is high and blood flow through the lungs is minimal. Most right ventricular output is shunted away from the pulmonary circulation via the ductus arteriosus and the foramen ovale, maintaining a parallel circuit between the systemic and pulmonary circulations. At birth, the removal of the placenta increases systemic vascular resistance, while lung expansion and the initiation of oxygenation cause a rapid drop in pulmonary vascular resistance. This transition redirects blood flow through the lungs for oxygen exchange, effectively converting the fetal parallel circulation into the postnatal series circulation, where pulmonary and systemic circuits operate sequentially. This physiological shift underpins the newborn's ability to oxygenate blood efficiently and is essential for the prevention of right-to-left shunting. Failure of this transition is the fundamental defect in persistent pulmonary hypertension of the newborn. Persistent pulmonary hypertension of the newborn occurs when the pulmonary vascular resistance fails to decrease appropriately after birth, preventing the normal transition from fetal to postnatal circulation. In the fetal state, the high pulmonary vascular resistance ensures that the right-to-left shunt through the ductus arteriosus and foramen ovale predominates, directing most cardiac output away from the non-functioning lungs. In PPHN, this fetal pattern persists, causing oxygenated and deoxygenated blood to mix and producing systemic hypoxemia refractory to standard oxygen therapy. The slide categorizes 3 mechanistic subtypes. Underdevelopment results from hypoplastic lungs, as seen in congenital diaphragmatic hernia or severe oligohydramnios, where both the vascular bed and alveolar surface area are insufficient for effective oxygen exchange. Maldevelopment involves structural remodeling of the pulmonary vasculature, characterized by excessive muscularization of arterioles, thickened vessel walls, and reduced capacity for vasodilation. Maladaptation is functional. Structurally normal vessels constrict excessively in response to perinatal asphyxia, sepsis, or meconium aspiration, often triggered by hypoxia, acidosis, or inflammatory mediators, leading to increased pulmonary vascular resistance. These mechanisms converge to create severe, refractory hypoxemia. Blood continues to bypass the pulmonary circulation via fetal shunts, and even maximal oxygen therapy may be insufficient. Clinically, this explains why affected infants exhibit profound cyanosis, require escalating ventilatory support, and may need targeted pulmonary vasodilators or extracorporeal life support. Understanding the specific underlying mechanism in each case informs both therapeutic strategy and prognosis, guiding decisions on the use of inhaled nitric oxide, prostacyclin analogs, PDE inhibitors, or ECMO. Persistent pulmonary hypertension of the newborn occurs in approximately 2 per 1,000 live births, with a higher prevalence in term and late preterm infants. Neonatal conditions frequently associated with PPHN include meconium aspiration syndrome, which accounts for 25 to 40% of cases, sepsis or pneumonia in 20 to 30%, respiratory distress syndrome in 10 to 15%, and congenital diaphragmatic hernia in 5 to 10%. About 15 to 20% of cases are idiopathic, with no identifiable underlying disorder. Maternal risk factors also contribute. Diabetes, obesity, advanced maternal age, and antenatal selective serotonin reuptake inhibitor exposure have all been linked to increased risk. Fetal growth restriction and oligohydramnios predispose to maladaptive pulmonary vascular responses, while black race has been identified as an epidemiologic risk factor, potentially reflecting genetic susceptibility or socio-environmental influences. The combination of maternal, perinatal, and neonatal factors increases the likelihood that the pulmonary vasculature will fail to transition normally after birth, resulting in persistent right-to-left shunting and systemic hypoxemia. Understanding these risk factors allows clinicians to anticipate potential complications and prepare for early monitoring and intervention. PPHN typically presents within the first 24 hours of life with hypoxemia that does not respond to standard oxygen therapy. Infants often exhibit tachypnea, retractions, and grunting, reflecting increased work of breathing caused by elevated pulmonary vascular resistance. Cardiac findings indicate right ventricular pressure overload. These include a prominent precordial impulse, a loud and narrowly split second heart sound, and a systolic murmur of tricuspid regurgitation. The underlying mechanism is persistent right-to-left shunting through the ductus arteriosus and foramen ovale, allowing deoxygenated blood to bypass the lungs and enter systemic circulation. Additional features may include cyanosis disproportionate to lung disease, poor perfusion, and variable hemodynamic instability, depending on the severity and underlying etiology. Recognition of these signs is critical for prompt intervention, targeted oxygenation, and initiation of therapies such as pulmonary vasodilators or extracorporeal support. Evaluation begins with continuous pre- and post-ductal oxygen saturation monitoring. A pre- versus post-ductal gradient greater than 10% suggests significant right-to-left shunting through the ductus arteriosus. Blood gas analysis typically shows partial pressure of oxygen less than 100 millimeters of mercury despite supplemental oxygen, while carbon dioxide may remain normal if the parenchyma is intact. Chest radiography is used to assess underlying lung disease. The slide shows that cardiac size is usually normal, but findings may reveal conditions such as meconium aspiration, respiratory distress syndrome, congenital diaphragmatic hernia, or pneumonia. A full sepsis evaluation is also essential, including blood cultures and empiric antibiotics, since infection is a common trigger for maladaptive pulmonary vascular responses. Integrating oxygenation data, imaging, and infection workup allows clinicians to confirm PPHN, evaluate severity, and guide early therapeutic interventions. Echocardiography is essential for confirming pulmonary hypertension and ruling out congenital heart disease. The slide shows that assessment includes right ventricular pressures, typically estimated via tricuspid regurgitation jet velocity, and septal flattening, which indicate elevated pulmonary artery pressures. Shunting patterns are evaluated, with right-to-left flow through the ductus arteriosus or foramen ovale confirming persistent fetal circulation. Ventricular function is assessed, noting that global dysfunction suggests perinatal depression or secondary myocardial compromise. Echocardiography also helps stratify severity, guide therapeutic escalation, and monitor response to interventions such as inhaled nitric oxide, vasodilators, or ECMO. It provides real-time, non-invasive evaluation of pulmonary hemodynamics, making it the gold standard for diagnosis and ongoing management. Severity in PPHN is assessed using both oxygenation indices and echocardiographic parameters. The oxygenation index is calculated by multiplying mean airway pressure by the fraction of inspired oxygen, dividing by arterial oxygen tension, and multiplying by 100. Mild PPHN corresponds to an index less than 15. Moderate ranges from 15 to 25, severe from 25 to 40, and very severe is 40 or higher. Echocardiographic assessment complements this by estimating right ventricular pressures relative to systemic blood pressure. Mild to moderate disease is indicated by right ventricular pressure at half to 3/4 of systemic pressure, whereas severe disease shows pressures equal to or exceeding systemic levels. These measurements guide clinical decisions, particularly the escalation to inhaled nitric oxide or extracorporeal membrane oxygenation. Accurate assessment of severity allows targeted therapy, optimizing oxygenation while minimizing ventilator-induced lung injury and systemic compromise. Management begins with stabilizing the infant's environment. Maintaining a neutral thermal environment and minimizing handling reduces oxygen consumption and prevents increases in pulmonary vascular resistance. Correcting contributing factors is essential. Metabolic disturbances such as acidosis, hypoglycemia, and hypocalcemia must be addressed carefully. Rapid correction of acidosis with bicarbonate can worsen intracellular acid-base balance and increase pulmonary vasoconstriction. Treatment of the underlying disease is critical. Surfactant may be administered for parenchymal lung disease such as respiratory distress syndrome, meconium aspiration, or pneumonia. Infection is treated promptly with empiric antibiotics while awaiting culture results. For structural causes like congenital diaphragmatic hernia, medical or surgical interventions may be required. These principles aim to optimize oxygenation, reduce pulmonary vascular resistance, and provide a stable physiologic platform for more targeted therapies, such as inhaled nitric oxide or pharmacologic vasodilators. This slide emphasizes multiple interventions aimed at reducing pulmonary vascular resistance and oxygen demand in infants with PPHN. The first category, minimized stimulation, includes clustered care and reduced handling to prevent catecholamine surges that trigger pulmonary vasoconstriction. It also highlights maintaining a quiet environment with low light and ear protection and limiting painful procedures while providing adequate analgesia, which collectively reduce stress-induced increases in pulmonary pressures. Next, optimized thermal stability focuses on maintaining a neutral thermal environment. Cold stress increases oxygen consumption, which in turn elevates pulmonary vascular resistance, so temperature control is essential. Under reduced oxygen demand, the slide recommends gentle positioning to minimize the work of breathing and appropriate sedation to prevent agitation, which can worsen hypoxemia and shunting. Support homeostasis includes correction of hypoglycemia, hypocalcemia, and metabolic acidosis, as well as maintaining normal electrolytes and hemoglobin, which supports adequate oxygen delivery and vascular function. Finally, family involvement is encouraged in a controlled manner. Provide supportive touch only when the infant is physiologically stable, and educate caregivers about stress reduction techniques. Each of these measures contributes to a stable physiologic platform, optimizing the infant's response to pharmacologic interventions. Management of PPHN includes targeted pharmacologic interventions through 3 key signaling pathways that regulate pulmonary vascular tone. The first is the nitric oxide cGMP pathway. Endothelial nitric oxide stimulates soluble guanylate cyclase, increasing cGMP in vascular smooth muscle cells, which causes pulmonary vasodilation. Therapeutically, inhaled nitric oxide, INO, is the first-line selective pulmonary vasodilator, and sildenafil, a phosphodiesterase 5 inhibitor, can augment the cGMP effect and support INO weaning. The second pathway is the prostacyclin CAMP pathway. Prostacyclin activates adenylate cyclase, raising intracellular CAMP and promoting smooth muscle relaxation. Therapies include inhaled prostacyclin analogs, such as epoprostenol or iloprost. Milrinone, a PDE3 inhibitor, also increases CAMP and provides inotropic support, improving both pulmonary vasodilation and cardiac output. The third pathway involves endothelin signaling. Endothelin-1 binds ETA receptors to induce potent vasoconstriction, while ETB receptors promote vasodilation through nitric oxide release. Bosentan, a dual ETA/ETB receptor antagonist, is used primarily for chronic pulmonary hypertension, with limited acute neonatal experience. Understanding these pathways is essential, as they explain why different agents are chosen based on mechanism, disease severity, and response to therapy, and they provide a framework for combination therapy in refractory cases. Oxygen acts as a selective pulmonary vasodilator by lowering pulmonary vascular resistance and improving right-to-left shunting. The target is productal oxygen saturation between 90 and 95%, avoiding hyperoxia, which can generate oxidative stress and reduce nitric oxide bioavailability. Gentle conventional ventilation is used initially, with tidal volumes of 4 to 6 milliliters per kilogram and positive end expiratory pressure of 5 to 7 centimeters of water, higher if atelectasis is present. These settings maintain alveolar recruitment while limiting barotrauma. Escalation to high-frequency oscillatory ventilation is indicated when the infant requires a fraction of inspired oxygen above 0.6. Peak inspiratory pressures exceed 28 to 30 centimeters of water, or if air leaks develop. Lung recruitment before initiating inhaled nitric oxide is critical because alveolar collapse limits the pulmonary vasodilatory response. Ensuring adequate alveolar ventilation maximizes oxygenation and improves the effectiveness of INO therapy. In PPHN, agitation increases catecholamine release, which elevates pulmonary vascular resistance and worsens right-to-left shunting. Sedation is therefore an important adjunct in management. Opioids such as morphine or fentanyl are used to reduce stress and oxygen demand, while benzodiazepines may be added if additional anxiolysis is required. Neuromuscular blockade is reserved for refractory cases with severe ventilator dyssynchrony, allowing precise control of ventilation and minimizing oxygen consumption from muscular activity. The slide emphasizes that these interventions carry risks of hypotension and prolonged paralysis, so they must be applied cautiously with continuous monitoring of cardiovascular status and ventilatory parameters. The combined use of sedation and selective neuromuscular blockade helps stabilize pulmonary pressures, optimize oxygenation, and improve response to pulmonary vasodilators. Effective hemodynamic support in PPPH focuses on maintaining systemic perfusion and optimizing right ventricular function while minimizing increases in pulmonary vascular resistance. The goal is to maintain a mean arterial pressure of 45 to 55 millimeters of mercury in term infants and ensure adequate tissue oxygen delivery. Lactate levels are monitored as a marker of perfusion. Volume management is carefully tailored. Routine fluid boluses are avoided because excessive preload can worsen right ventricular failure. If true hypovolemia is suspected, small boluses of 10 milliliters per kilogram, repeated once or twice if necessary, may be given. Vasoactive support is selected based on physiologic principles. Dobutamine improves both right and left ventricular function with minimal impact on pulmonary vascular resistance. Norepinephrine supports systemic blood pressure and helps balance the pulmonary to systemic resistance ratio. Vasopressin can provide selective pulmonary vasodilation, particularly in refractory cases. Epinephrine may be considered for ventricular dysfunction with shock, while dopamine is generally avoided due to its potential to increase pulmonary vascular resistance. Tailoring volume and vasoactive therapy to the infant's hemodynamic profile ensures adequate oxygen delivery while reducing strain on the pulmonary circulation and supporting the response to targeted pulmonary vasodilators. Inhaled nitric oxide is a selective pulmonary vasodilator that targets the pulmonary circulation without causing systemic hypotension. It is indicated in PPHN for infants with oxygenation index of 25 or higher who remain hypoxemic despite optimized ventilation, sedation, and correction of metabolic disturbances. The mechanism involves diffusion into pulmonary vascular smooth muscle cells, where nitric oxide activates soluble guanylate cyclase, increasing cyclic GMP levels and causing relaxation of pulmonary arterioles. This reduces pulmonary vascular resistance, decreases right-to-left shunting through the ductus arteriosus and foramen ovale, and improves arterial oxygenation. Therapy is initiated at 20 parts per million, and response is expected within 15 to 30 minutes, allowing rapid assessment of efficacy. INO must be weaned gradually to prevent rebound pulmonary hypertension, initially by 5 parts per million every 2 to 4 hours down to 5, then 1 part per million every 2 to 4 hours to 1. During treatment, methemoglobin levels are monitored to prevent toxicity, and oxygenation response is tracked via productal saturation and arterial blood gases. INO acts as a bridge therapy, improving oxygenation while underlying pulmonary or systemic causes, such as parenchymal lung disease, sepsis, or structural anomalies, are treated. Understanding the pharmacodynamics and precise weaning protocol is essential to maximize benefit while minimizing complications like rebound hypoxemia or methemoglobinemia. Surfactant therapy in PPHN is indicated primarily when underlying parenchymal lung disease is present, such as meconium aspiration syndrome, respiratory distress syndrome, or pneumonia. In these conditions, alveolar collapse, edema, and surfactant inactivation worsen hypoxemia and contribute to persistent pulmonary hypertension. Administration of exogenous surfactant restores alveolar surface tension, improves lung compliance, and promotes alveolar recruitment, which increases pulmonary blood flow and oxygenation. Clinical evidence shows that in PPHN, secondary to MAS or sepsis, surfactant therapy can reduce the need for ECMO and improve oxygenation parameters. However, surfactant is not first line for isolated PPHN without lung disease, as it does not address elevated pulmonary vascular resistance in structurally normal lungs and may transiently increase bleeding risk in unstable infants. Timing and dosing are critical. Surfactant should be given after initial stabilization and optimization of ventilation to maximize alveolar recruitment and gas exchange. Additional therapies in PPHN target adjunctive pulmonary vasodilation and cardiac support. Sildenafil, a phosphodiesterase 5 inhibitor, is used orally or intravenously to augment cyclic GMP, enhancing the effect of inhaled nitric oxide and facilitating weaning. Caution is required with intravenous administration due to the risk of systemic hypotension. Milrinone, a phosphodiesterase 3 inhibitor, improves myocardial contractility while reducing pulmonary vascular resistance. It acts as an inodilator, improving right and left ventricular output, and is often used in combination with INO in infants with myocardial dysfunction or refractory pulmonary hypertension. Prostacyclin analogs such as inhaled epoprostenol or intravenous/subcutaneous treprostinil provide potent pulmonary vasodilation through increased cyclic AMP. Their use in neonates is typically reserved for severe or refractory cases under specialist guidance. Endothelin receptor antagonists such as bosentan block endothelin-mediated vasoconstriction. Their role is mainly in chronic pulmonary hypertension, with limited evidence for acute neonatal use. These therapies are often employed when standard INO therapy is insufficient, and understanding the mechanism of action, pharmacokinetics, and potential systemic effects is crucial for safe, effective use in critically ill neonates. Extracorporeal membrane oxygenation is reserved for infants with refractory hypoxemia, typically when the oxygenation index reaches 40 or higher, despite maximal conventional therapy, optimized ventilation, and pulmonary vasodilators. ECMO provides temporary cardiopulmonary support, allowing the pulmonary vasculature and myocardium time to recover while ensuring systemic oxygen delivery. The goal is to maintain adequate oxygenation and perfusion without further ventilator-induced lung injury. Typical ECMO courses last 7 to 10 days, but may extend beyond 2 weeks in severe cases. Survival rates for neonates on ECMO are approximately 69%, according to ELSO registry data, with outcomes influenced by gestational age, underlying lung disease, and comorbidities. ECMO requires specialized multidisciplinary management, including anticoagulation, careful monitoring of perfusion, and ongoing assessment of pulmonary vascular resistance. It is a bridge therapy, not definitive treatment, allowing time for the underlying cause of PPHN to resolve or be corrected. Monitoring respiratory function in PPHN focuses on continuous assessment of oxygenation, ventilation, and gas exchange. Preductal and post-ductal oxygen saturations are measured continuously to detect right-to-left shunting and guide therapy. Serial arterial blood gases are obtained to track preductal PaO2 and calculate the oxygenation index, which informs severity and escalation decisions. Ventilator parameters, including peak inspiratory pressures, tidal volumes, and positive end expiratory pressure, are closely monitored to ensure adequate alveolar recruitment while minimizing barotrauma. When inhaled nitric oxide is used, methemoglobin levels are periodically checked to avoid toxicity and ensure safe delivery of therapy. This intensive monitoring allows early detection of deterioration, assessment of response to pharmacologic interventions, and timely adjustments in ventilatory support, optimizing oxygen delivery and reducing the risk of secondary organ injury. Hemodynamic monitoring in PPHN is critical to balance systemic perfusion with pulmonary vascular resistance. Continuous arterial blood pressure monitoring allows rapid detection of hypotension or hypertension, which can exacerbate right-to-left shunting. Serial lactate measurements provide insight into tissue perfusion and oxygen delivery, indicating whether cardiac output is adequate. Echocardiography plays a central role in ongoing assessment. It estimates right ventricular pressures and identifies the direction and magnitude of shunting across the ductus arteriosus or foramen ovale. Ventricular function is evaluated, with global dysfunction suggesting perinatal depression or myocardial compromise secondary to hypoxemia. Serial echocardiograms also guide titration of pulmonary vasodilators, inotropes, and fluid therapy. Chest imaging, including serial radiographs, may be used to track lung volumes, alveolar recruitment, and acute changes such as air leaks or evolving infiltrates. Combined, these respiratory and hemodynamic assessments allow precise adjustment of ventilation strategies, vasoactive medications, and targeted pulmonary vasodilators, ensuring adequate oxygen delivery while minimizing additional strain on the right ventricle. PPHN carries a mortality rate of 7 to 10% in high-resource neonatal intensive care units, though risk increases significantly in infants with congenital diaphragmatic hernia, severe pulmonary hypoplasia, or refractory hypoxemia. Most deaths occur within the first week of life, reflecting the rapid onset of severe hypoxemia, right ventricular strain, and multi-organ compromise. Survivors are at risk for neurodevelopmental sequelae, including cognitive and motor delays, as well as attention and learning difficulties. Sensory neural hearing loss affects up to 25% of infants, necessitating audiology screening prior to discharge and at 18 to 24 months. Chronic morbidity is common, particularly in infants with underlying parenchymal lung disease. This includes reactive airway disease, chronic pulmonary hypertension, and recurrent hospitalizations, with roughly 30% experiencing complications within the first year. These outcomes underscore the need for comprehensive monitoring, early intervention, and longitudinal follow-up to optimize long-term health and development. Persistent pulmonary hypertension of the newborn is defined by failure of pulmonary vascular resistance to decrease after birth, resulting in persistent right-to-left shunting and systemic hypoxemia. The condition can be secondary to meconium aspiration, sepsis, respiratory distress syndrome, or congenital diaphragmatic hernia, or it can be idiopathic. Diagnosis relies on echocardiography to confirm pulmonary hypertension and exclude congenital heart disease, combined with clinical assessment of oxygenation, ventilation, and hemodynamic stability. Management focuses on stabilization, optimization of oxygenation and ventilation. Targeted pulmonary vasodilator therapy, such as inhaled nitric oxide, and escalation to ECMO in refractory cases. Despite advances in care, mortality ranges from 7 to 10%, and survivors remain at risk for chronic pulmonary morbidity, neurodevelopmental impairment, and sensory neural hearing loss. Early recognition, careful monitoring, and timely intervention are critical to improving both acute outcomes and long-term prognosis.